So yeah guys, welcome to final year, and in today's video we'll be talking about specific management of fractures. So right, we'll talk about management of fractures. Okay, so the general principle what we will follow, that will be emergency care, then definitive care, then rehabilitation. That what we will do in emergency care, and then what we will do for definitive care, that once emergency treatment had given, then what we will do for definitive care and then rehabilitation. Okay, these will be our general principles of treatment of fractures. So, right, phase one, emergency care. Emergency care. In emergency care, what we will see at the site of accident. First, we will see at the site of accident. That what we will do at the site of accident where the accident has occurred. So for that, there is mnemonic to remember: RICE, RICE. So rest to the part. Whatever part has been fractured or injured, that part should be rested. Okay. Then next, ice therapy. Ice therapy to reduce or the occurrence of the swelling. Okay. Then compression and elevation. These two also for the reduction of the swelling only. Okay. Then next we have in the emergency ward department, emergency department, like after reaching the hospital. Okay. So there we will be giving the patient wound care, then splints to reduce the mobility, then prophylactic antibiotics we will give, tetanus prophylaxis, analgesics to reduce the pain, and then X-ray for the diagnosis that where the fracture and what type of fractures are there. Okay, yeah, right. Then next we have phase two. That's it. That is definitive care. That what we will give him for the proper treatment. So there we have fundamental principles. These are reduction, immobilization, and preservation of functions. First, we will do reduction, then immobilization of the that part, and then preservation of the functions of that part. So reduction, what we will be having? We will be having reduction open or close. Immobilization, we will see later that we have internal immobilization and external immobilization. Okay, and then preservation of the functions. Right. Then we here we have indications of the open reduction, that when we will do the open reduction for the definitive care, right? So we have absolute indications and relative indication that I have taken from Maheshwari. So that absolute indication is failure of close reduction, displaced intra-articular fracture, then some displaced epiphyseal injuries like type 3 or type 4, and major avulsion fractures, example, जैसे fracture of patella. Then non-union fractures are there, like the fracture which is not healing, then we have to go for open reduction. Relative indications, what are there? Delayed union and malunion, then multiple fractures, pathological fractures, where closed reduction is known to be insufficient. Okay, like fracture of the neck of the femur. Here, if the fracture is in the neck of femur, then it is not possible for us to reduce it closely, or we know that it will be insufficient or ineffective for the fracture of neck of femur. Then fractures with the vascular or neural injuries. Okay, so these were the indications of the open reduction. These has been asked in the exams for our college purpose also, and for MCQ also. Then immobilization. Immobilization indications. What all indications we will be having for immobilization? We know that not every fracture needs immobilization, right? So some indication will be there to prevent displacement or angulation. Okay, to prevent movements, then to relieve the pain. These three conditions or indications we will be having for immobilization, right? Then methods of the immobilization. What are the methods of the immobilization? These are non-operative methods and operative methods. In non-operative methods, we have strapping, sling, cast immobilization, which we call plaster of Paris, functional bracing, splints, and traction. Then operative methods. In operative methods, we have internal fixation and external fixation, right? So we'll talk about cast immobilization and splints. Okay, these have been asked in our exam. So cast immobilization is plaster of Paris only. So here is the formula of plaster of Paris: CaSO4 dot half H2O, that is in dry condition. So use of POP, how we can use it as a slab, we can use it, or as cast we can use it. As a slab is like when we are partially doing some plaster, okay, and what all we have seen, that is as a cast. जो हम plaster of Paris का जो पट्टा दो देखते हैं हम किसी के फ्रैक्चर के पाँव पे बंधा हुआ, that will be as a cast. Then we have principles. What all principles will follow? Immobilize the joint above and below the fracture. कि जो फ्रैक्चर जो पार्ट है उसके ऊपर वाला और उसके नीचे वाले जॉइंट को इमोबिलाइज कर देना है. देन इमोबिलाइज इन फंक्शनल पोजीशन. ऐसा नहीं है कि किसी भी पोजीशन में इमोबिलाइज कर दिया है हमने पार्ट को, हम उस फंक्शनल कंडीशन में या फिर फंक्शनल पोजीशन के अंदर इमोबिलाइज करेंगे उस जहां पर भी जिस भी पोर्शन में फ्रैक्चर हुआ है उसके रेस्पेक्ट में. देन पैड द लिम्ब एडिक्वेटली. अगर हमने पैडिंग एडिक्वेटली नहीं किया तो क्या होगा कि डिस्टल टू दैट पार्ट we will be having avascularization, okay. And after that, after care of the plaster, once we have done the plaster, what all care we should take care, that is cracks. If some cracks are taking place, then we should take care of that. Then no wetting, that plaster should not get wet, okay. So that we should take care. And then exercising of that muscle part, that also we have to take care, okay. Then we have complications. What are the complications of plaster of Paris? Like we are doing a POP, then what are the complications? Impairment of circulation. That I have told you that if it is very tight, we have plastered very tightly, then it is possible that we will land up ultimately we will land up in the impairment of circulation. And then plaster sores, that the patient is not able to feel his distal part of the fracture, then pain is there, then he can't take sleep. These all things are the plaster sores, okay. Right, so we'll talk about splints. In splints, among all of them, we have just one is there of the our importance, that is Thomas splint. We'll talk about that. That parts are there. So this one is the ring, and these are the two sidebars. So ring and sidebars are the two parts. So how we will calculate the size of the Thomas splint, that I have taken from the Maheshwari. You read this. Then usage, how and where we use it for immobilization of the lower limb, we use it, okay. So here that is this portion, we can see this is a ring, then two sidebars are there. Then this also can be asked for drawing while in short answer or something, right. So then we have type of immobilization, that is internal fixation and external fixation, right. So in that is operative type. Internal fixation is done by steel wires, then Kirshner's wire, then intramedullary nail, screws, plates and screws, okay. एंड एक्सटर्नल जो फिक्सेशन जो है वो हम करेंगे पिन फिक्सेटर्स एंड रिंग फिक्सेटर्स, ओके, राइट. Right, so we have phase 3 now, that is rehabilitation. In rehabilitation, what we will do? Joint mobilization, muscle re-education exercises, and functional use of the limb. Okay, right. So now I have taken these flow charts from Maheshwari to understand that what we will be the general plan for the treatment of fracture. So what we will do? Fracture we have, then examine for the neurovascular deficit, if any there, if undisplaced or displaced. Display undisplaced is there, then immobilization, then physiotherapy. Okay. If displaced is there, like fracture is display, the part has been displaced, then what we'll do? We have to close reduction or primary open reduction and internal fixation. In close reduction, manipulation and traction we will do. Then acceptable position we will gain and then immobilize. Then physiotherapy, same. Then unacceptable position. If unacceptable position is there that patient can't bear, then open reduction, internal fixation, and then physiotherapy. Okay. Then primary open reduction and internal fixation. If it is displaced, okay, and it is not bearable, then we'll go for primary open reduction and internal fixation, and then physiotherapy. Okay. Then next I have taken this plan for wound closure in open fractures. If open fracture is there, then what we will do? Wound debridement we will do. Then small puncture wound. If a small puncture wound is there, then we will leave it. Clean lacerated wound is there, then primary closure we will do. Doubtful lacerated wound is there, then we will observe for 2 to 3 days. Then if no infection is there, then delayed primary closure we will do. If infection is there, then secondary closure we have to do. If wound is infected wound is there, then healing by secondary intention. Okay, so these are the this one was the general plan for the treatment of fractures, and this one is for the wound closure in open fractures. So right, that's it for this video. Do follow, do subscribe. Thank you.